Hello, everyone. My name is Dr. Oscar L. Hernandez, first year internal medicine resident at Florida Atlantic University's College of Medicine, alongside my colleagues Drs. Akwopo, Goyal, and Gaizinskaya. And today we would like to present a case which demonstrates a rapidly fatal conversion of acute edematous pancreatitis and highlight a need for better risk stratification protocols. For some background, acute pancreatitis is inflammation of the pancreas which may lead to local and systemic complications. Pancreatic necrosis, bowel necrosis, and SIRS are all conditions and complications associated with acute pancreatitis. Classically, acute pancreatitis is classified using the revised Atlanta classification system, which considers a multitude of factors including timing of symptoms, pancreatic morphology on cross-sectional imaging, and the severity of disease based on local and systemic factors, which can be stratified using the modified Marshall scoring system. Risk stratification with BISAP scoring and Ranson criteria is often used when approaching acute pancreatitis in a clinical setting. Our case involves a 67-year-old female with a history of hypertension, prediabetes, and a previous cholecystectomy who presented with acute onset epigastric abdominal pain associated with nausea and vomiting. On initial CT of the abdomen, we found evidence of edematous pancreatitis without necrosis or necrotic collections. She was diagnosed with acute, early, interstitial edematous pancreatitis according to the revised Atlanta classification system. BISAP score initially was 0, representing a predicted mortality of less than 1%, and Ranson's criteria were 3, representing a predicted mortality of 15% approximately. No evidence of hypertriglyceridemia, hypercalcemia, gallstones, or other identifiable etiologies were found at time of presentation. She was initiated on IV lactated ringers, a low-fat diet, and opioid pain control. By admission day 2, she became increasingly tachypnic with worsening oxygen requirements and renal function. We considered repeating a CT scan of the abdomen to potentially look for a necrotic conversion of her pancreatitis. However, she developed an acute respiratory failure and went into shock, requiring emergent intubation and the initiation of multiple vasopressors by the evening of admission day 2. It was decided to do an exploratory laparotomy, which found hemorrhagic pancreatitis, gastric ischemia, diffuse gangrenous bowel necrosis, and a pulseless SMA. Extensive resection from rectum to duodenum, leaving only approximately 20 centimeters of viable duodenal tissue distal to the ligament of Treitz, was performed. She remained in critical state postoperatively with multiple hemodynamic complications, and ultimately comfort measures were pursued per family wishes. On imaging, we see outlined here is the acute presentation of an interstitial and edematous pancreatitis on the original CT imaging of the abdomen. Figure 2 represents what came out of the resection, and it demonstrates gangrenous bowel necrosis and ischemia. So this case illustrates the potential for rapid conversion of interstitial edematous forms of pancreatitis to necrotic pancreatitis despite low risk on initial predictive models. It is hypothesized in our patient that she suffered extensive bowel ischemic events as a result of SMA vascular complication from her rapidly progressing pancreatitis, as well as ischemia secondary to SIRS and inflammatory third spacing. These complications, including gastric ischemia, are rarely reported in acute pancreatitis. We considered earlier surgical intervention in this patient. However, a UK study notes that early surgical intervention in cases of acute edematous pancreatitis is actually associated with an increased mortality. In conclusion, we think that current scoring models lack positive predictive value in predicting persistent organ failure within the first 48 hours of presentation of acute pancreatitis. A study by Monsner et al. Report on the need for improved models for predicting persistent organ failure in acute pancreatitis. Clinical judgment should not be biased towards conservative interventions using these predictive models alone, and frequent evaluation and monitoring of clinical course should inform decisions on more aggressive interventions. We would really like to highlight the importance of clinical evaluation in patients with acute pancreatitis and understand that relying on initial risk stratification models at this time is not the best sole measure when approaching these patients. Thank you.